Okay, so aerosol generation and mitigation in dental practices. Again, I'm Dr. Kirsten Kroling. I'm the Chief Education Officer here. This is a course that I've been presenting now, I think, for 5 or 6 years. There's my conflict of interest. And again, for those of you attending live, be sure to refer to the agenda and CE credit instructions. For those of you watching the recording later, all you need to do is scroll below this video player. You'll see a section that states instructions. You can download the handout and take the quiz directly from our website. An email is not sent to you for this. Our learning objectives will identify procedures at high risk for aerosol production, describe transmission precautions for aerosol generating procedures, implement administrative controls and engineering controls to reduce aerosol, and discuss technologies to assist dental practices with aerosol mitigation. When we talk about aerosol, we're talking about potential routes of disease transmission in the dental office. So how does the disease transmission occur? Well, it can occur through direct contact with our patient or with body fluids of an infected patient, contact with environmental surfaces or instruments that may have been contaminated by the patient, or contact with infectious particles from the patient that have become airborne or aerosolized. When we talk about aerosols, we're talking about particulate matter that is classified based on diameter. All right, so we talk about spatter. Spatter are the larger particles, and you're going to see this on the quiz, greater than 50 microns, and they behave like ballistics, as we'll talk about here. Droplets are particles that are less than 50 microns or micrometers in diameter, and droplet nuclei, which are less than or equal to 10 microns. You're going to hear Glory talk about the ultra-fine particles, and those particles are very, very, very small in diameter. When we talk about droplets, we're talking about particulate matter that is extremely light in mass. It floats around in the operatory and in your dental practice. It doesn't just hang out in the operatory. And the smaller these particles are, the more deeply they can embed in the respiratory tract. And the very fine or ultra-fine particles can actually affect every organ in your body. And you'll hear Glory talk about this. So droplet nuclei, because again, they are very light in mass, can stay airborne for extended periods of time before they eventually settle on our environmental surfaces or enter the respiratory tract. And those environmental surfaces may not be a countertop, or they may not be the floor. They might be your hair if you're not covering your hair, or your face, or your forearms if you're not covering your forearms, or the patient's tray, or the patient, and so forth. Now, when we think about our dental practices, we have to remember that dental practices are unique in healthcare because just about every procedure we perform generates aerosol. Right? Even our examinations can generate aerosol. We might be using the 3-way air water syringe to isolate a tooth or improve visibility, right? You're generating aerosol. When you go to a primary care physician's office right now, they will enter the operatory, or in this case, the examination room. They're going to basically interview you. They'll be sitting about 12, 15 feet away. And they're going to ask you a few questions. They're going to enter notes into their laptop. Maybe they'll make some recommendations, maybe some laboratory orders or some prescription that they're going to have sent to your pharmacy. But the aerosol generated is basically from tidal volume breathing or conversation, or if somebody has a cold or a cough. But when you go to a dental practice, or you are working in a dental practice, you are immersed in aerosol. That aerosol, again, doesn't just stay in the operatory. And depending on how well you're cleaning the air, monitoring your air quality through different zones close to the patient, zones in your operatory and beyond, will depend on, you will be dependent upon that exposure and your occupational risk for being in that practice. All right. So again, particle size is relative to respiratory deposition. Large particles greater than 5 microns tend to deposit mainly in the upper and large airways and limits the aerosol that is delivered to the lung. Now, the smaller particles, 2 to 5 microns, deposit preferentially in the central and smaller airways, and the very small particles, less than 2 microns, deposit mainly in the alveolar region. And the ultrafine particles that you'll hear Glory talk about, again, can penetrate beyond the alveolar region, and they can affect every organ system in the body. Okay, so when we talk about spatter, this was a study that we're going to talk about. And remember, spatter are the larger particles, larger than 50 microns in diameter. When you think of a micron is 1/1,000,000th of a meter. So spatter is still relatively small in diameter, but these are relatively larger compared to the nuclei and the droplet nuclei. So these particles behave similarly to ballistics, or what we would call bullets. If you recall physics, a bullet tends to travel in a trajectory, right? Eventually falls to earth. In your operatory, which is a smaller enclosed environment, these large particles behave like ballistics, but they start bouncing around, right? They're not going to have the opportunity necessarily to arc. And so they can bounce around off the walls, off your face mask, off your gown, off the countertops, off your patient, and so forth. You get my gist here. And eventually they run out of steam and they fall to earth. And again, the question is, where do they land, right? Do they land on you or your patient or the patient tray or a countertop or the flooring, etc.? So these particles size, the spatter greater than 50 microns, are too large in mass to become suspended in the air. So they're airborne only briefly. And again, let's review the droplets and droplet nuclei. So droplets, as we said, can remain suspended in the air until they evaporate, and they leave behind these droplet nuclei that are very light in mass, but they contain pathogens, bacteria, for instance, related to respiratory infections. Now, the droplet nuclei, these evaporated form of droplets, can contaminate surfaces in a range of 3 feet, and they may remain airborne for 30 minutes to a couple of hours. And they don't just stay in your operatory. They can travel on out to the business office, down to your reception area, your business, your personal office, and so forth. All right. So again, the problem that we're concerned about here, and even prior to COVID, is that when inhaled, these droplet nuclei can penetrate very deeply into the respiratory system. And of course, as we said, the ultrafine particles can affect any organ in the body, any and every organ in the body. What do we need to be concerned about with our patients, especially right now? COVID is on the rise, folks. It's not as prevalent in our face because many people aren't testing, but it's out there, trust me. All right. And we have patients that are more susceptible to not just COVID, but other infections that can be caused by these airborne pathogens. So the susceptibility of a host developing an infection is influenced by what? Virulence. When we talk about a virus, for instance, not all viruses are alike. They're not all as robust. They're not all as efficient in transmitting infection. Dose So how many viral particles would be required that we would need to come into contact with to become ill? Pathogenicity of the microorganism, and then host immunity. So that person who is the potential host, are they immune to this infection or partially immune perhaps through vaccination or prior infection? Now, in my case, I got COVID in a hospital, right? And I'm pretty sure I took a significant hit. So with many of these viruses, virulence also depends on the dose. How many particles we came into contact with can also affect severity of illness. And I'm pretty sure that I was blasted where I was. All right, so this is just a very good graph here. We don't need to just be concerned about respiratory illness, although we should be. We have other types of transmission of infection that can occur in a dental practice, where those bacteria, viruses, even fungi can become re-aerosolized because we're in an environment, again, that generates aerosol. So when we talk about, when we're looking at this graph, we're talking about an infected individual. This infected individual that walks in our dental practice, they might be carriers. They may not even know they're ill. They may be shedding virus through respiratory secretions, but also fecal discharge, right? You're thinking, well, Dr. Rowling, in a dental practice, we're not dealing with feces here. Well, you are indirectly at times. Because of the oral fecal route, we have to discuss cross-contamination, contamination of your surfaces, re-aerosolization of things like norovirus. When we talk about bacteria, re-aerosolization of Clostridium difficile spores, which contaminate the healthcare environment. All right, so again, here's our friend, the droplet nuclei, less than 5 microns, and they travel float around in the operatory because they're very light in mass until they reach a surface or perhaps a susceptible individual. And these droplet nuclei, again, very small in diameter, very light in mass, are the evaporated nuclei. And we also said the ultrafine particles that Gloria will be talking about later, very dangerous. All right, also direct contact. So we can come into direct contact with some of these droplet nuclei floating around, or also indirect contact. We may touch a surface that has been contaminated with aerosol, etc. So again, infectious virus transmission can involve a combination of both respiratory and fecal oral routes. Excuse me. Talking about aerosol here. Okay, aerosol source. Dental instrumentation, saliva, respiratory sources, dental handpieces, ultrasonic scalers, and air water syringe. Okay, I should be a good walking commercial for why we need to improve aerosol in healthcare settings. When we look at the aerosol source in our dental practices, we of course have to look at the oral cavity because 700 plus pathogens, bacteria from the respiratory tract, including the nasopharynx and the lower pulmonary system, and may include gingival crevicular fluid, tooth preparation, and dental materials, all aerosolized. Now, when we look at first our ultrasonic scalers, and many of you may recall early on in the pandemic, there was quite a bit of emphasis on ultrasonic scalers because the tests out there demonstrated the highest concentration of small droplets in zones nearest the patient, less commonly up to 8 feet away, emitted by these ultrasonics. Particle sizes were consistent with those that carry infectious agents. And to mitigate when we're using ultrasonic scalars, we should emphasize initially the regions nearest to the procedure, including using our PPE, so eye protection, mask, face shield, and the use of evacuation devices. And I can't emphasize enough the need to cover your hair. I know it's not beautiful and glamorous, but there are some hair bonnets out there that are kind of stylish. The reason is the amount of aerosol that you're exposed to. Your hair is covered, laden with this aerosol. And so you may be leaving your practice and getting in your vehicle, and those particles may not just stay in your hair. They may fall on a surface in your vehicle, in your home, picking up your child at childcare, hugging your wife, etc. So I would strongly urge you to cover your hair as well as your face. High-speed handpieces, data demonstrated here that all 4 dental procedures that were tested in this particular study generated spatter, droplets, and aerosol contamination up to 120 centimeters away from the source. And among the 4 AGPs here, aerosol generating procedures, the high-speed handpiece generated the most contamination. So we have to have precautions in place to reduce the aerosol, the droplet and spatter contamination during our dental procedures, and should be used in the treatment of all dental patients at all times. I'm going to be showing you a YouTube video here in just a second, but this was the University of Minnesota. These were researchers that tested several filtration devices in a study that they believed could increase health safety in dental practices. And this was during the COVID-19 pandemic. But again, I want to remark that these issues existed prior to COVID-19. And many of these studies existed prior to COVID-19. So I'm going to go ahead and play the video for you. So they are, this one actually, they're using a handpiece, I believe. But they show how they mitigate the aerosol almost completely by using an extraoral, what they call local extractor filtration. And you can see when they turn it on, they sound like they might be German. And again, if you cannot hear the video, the link is there for you in your handout.
So both are on. 3, 2, 1. Both are on. 3, 2, 1.
Okay, so based on that, when you see the amount of, that was ultrasonic, when you see the amount of aerosol being generated in just that procedure, this is why I have concerns about not covering your hair and your face with a face mask, because you are being exposed to quite a bit of aerosol. And it can be a cumulative problem for clinicians. All right, let's talk now about low-speed handpieces. Research concluded in this study that by using an electric drill rather than an air-driven handpiece led to a 99.98% reduction in aerosol spread of the virus into the air. And when a dental evacuation device was added, there was no detectable virus on surfaces or in air samples taken 6 to 10 minutes afterwards. So the results here showed that by replacing high-speed handpieces with lower speed electric drills when you can, aerosol spray was virtually eliminated, creating a safer environment for both patients and the dental team. I started in dentistry as a registered dental assistant, and we had, this is how long ago it was, some of the practices still had belt-driven handpieces. So those handpieces emitted less aerosol, and the practices then, many of them were operatories that were drywalled in, right? So they were their own rooms. So you were probably exposed to less aerosol, which was a good thing because we didn't wear PPE in 1981, right? No mask, no eye protection. It was routine for me to develop conjunctivitis now and then, or get something in my eye, or get stuck on a dirty scaler that was thrown in a sink. I mean, that's the way it was. But now, because we do have these high-speed handpieces, air-driven, much more aerosol, and we have dental practices that are open bay, right? So the aerosol is easier for these particles to float around. Sharon makes the comment here that they have an electric handpiece now. All right, low-speed handpieces again, electric drill rather than an air-driven drill, 99.8% reduction in aerosol spread. Okay, air polishing. Many of you perform air polishing in your practices, and the concern here is that the aerosol cloud that is emitted during the air polishing can be quite hazardous. Now, the concern is systemic effects, infection control. If you've environmental surface contamination because of the contaminated particles, sodium bicarb powder, water, and then also organic material from the patient and inorganic material. If you've ever been in a practice that uses air polishing, some of the practices, you can put your hand on the surface, you can feel the fine film of the polishing material, right? So this was an in vitro study that they evaluated an aerosol reduction device designed for use during air polishing. And the results here, the mean contamination without using an aerosol reduction device was 175.59 centimeters squared per centimeter squared. The mean contamination with the aerosol reduction device was 4.37 centimeters squared. That's a greater than 97% reduction in aerosol contamination. So these were measurements of the area. Now, the conclusion here is that the aerosol reduction device significantly decreased the contamination produced during air polishing. So if you are using air polishing in your practice, hopefully you have significant intraoral and extraoral air mitigation devices that you're using, because that fine particles are not good for you. All right, air water syringe here, bacterial counts indicate that airborne contamination is nearly equal to that of an ultrasonic scaler. High volume evacuators will reduce airborne bacteria by nearly 99%. And this was a study, aerosols and splatter in dentistry. This was all the way back in 2004 by Dr. John Molinari, one of the co-researchers. Laser plume, electrosurgery, and cryosurgery. So the airborne dispersal of low risk and high risk HPV DNA during the ablation of HPV associated lesions is well documented. What does that mean? It means that gynecologists that have removed HPV lesions from the cervices or cervix of patients who had HPV infection using laser or electrosurgery and cryosurgery, it develops or produces a plume. And they've inhaled that plume because they have not protected their airway and they have not used any sort of extra aerosol mitigation. And what happens is that these gynecologists have developed these lesions in the oropharyngeal area with matching HPV genotypes in the surgical smoke and then the corresponding tissue that was treated with a CO2 laser. So when we talk about infectious diseases caused by aerosol person to person, we're talking about rhinovirus, for instance. Rhinovirus is your sinus or cold virus that goes around, usually seasonally. Tuberculosis, influenza, which is starting to see an uptick. Legionnaire's disease, which is fungal found in air conditioners that were not well cleaned in the water of air conditioners. Certainly coronavirus, SARS-CoV-1 and SARS-CoV-2, and then other bacterial and viral diseases. So we're going to talk a little bit now about infectivity and virus shedding of emerging and re-emerging viruses. And again, we were talking about the dosage of exposure, right? And the how robust this virus is. Some viruses are less so, requires more viral particles. The infectivity of a virus refers to its ability to initiate infection of a host cell with production of viral progeny. What does that mean? So we look at what's called ID50, the infectious dose 50. That is the smallest number of infectious virus particles that will lead to infection of 50% of an exposed population. So this is dependent upon what? Species, age, or race of the host, the receptor, the immune and nutritional status or the constitutional status of the host or host tissues, and the portal of entry of the virus. So in the case of most viruses or viral infection, only a percentage of those infected actually develop clinical illness, which is part of a problem with SARS-CoV-2. We have folks out there that are infected and they don't know it, and we're not testing anymore, and these people are going to work. In fact, here in Arizona, I was looking to see if I had my discharge papers from urgent care. In the discharge papers I have, it said, as long as you don't have a fever, which I did, but as long as if you don't have a fever, whether you're symptomatic or asymptomatic, you don't need to isolate anymore in Arizona. What does that mean? People are going to work. What else? Well, we're not testing anymore, and the government's not paying for these tests. So guess what? They're like $150 to $250. My PCR test was $250, and I had 2 of them. Right? They said, we're going to bill this to your insurance, but chances are you're probably going to have to pay for this. Now, given those economics and the fact that patients are being told in many states that they can just go back to work, you're going to have employees come to work that are infected with COVID. And what are you going to do about that? It's just like, in the old days when we had to worry about flu every flu season. You always had 1 or 2 that came into office, they're hacking around you, they're sneezing around you. And the next thing you know, the whole office is sick and you have people taking off or they continue to come sick. This situation with COVID, though, is a little bit trickier, right? You have folks at home who may have children going to school, etc. But we also have to worry about our patients who are at higher risk. Older adults, higher risk for hospitalization and death. Those of our patients that are immunocompromised, we might have patients on steroids, for instance, for a number of conditions, maybe asthma, patients that are on antivirals for HIV, or they may be being treated for other conditions, Crohn's disease, rheumatoid arthritis. These patients come into your office. Well, the question I have is, how are we going to protect them? If folks are coming to work ill, healthcare providers are not required to mask anymore. Our administrative controls have sort of been put on the back burner. What are we going to do? And that's a question that I ask. So I just put it out there. Infectivity, again, exposure to as low as one infectious viral particle has the probability of causing an infection leading to disease, although that probability varies from virus to virus. So we spoke about ID50, and these are values that reflect the doses capable of infecting half of the subjects exposed, 50% of the infective dose. Now, in the case of Ebola virus, for instance, 1 to 10 infectious aerosolized Ebola virus particles can cause an infection in humans. One viral particle. Compared to influenza virus, infectivity values specific to H5N1, H7N9 strains, they don't have availability currently, but they estimate that 100 to 1,000 infectious viral particles have been reported. And of course, it's thought that SARS-CoV-2 various strains are thought to have very low ID50 values. Remember, we had COVID, and then or SARS-CoV-2, and then we had Delta, when we were told, okay, if you're vaccinated, you can go out into the world, you don't need to wear a mask and so forth. And then Delta hit, right? Oh, Delta is much more infectious than the initial SARS-CoV-2. And then we've had the subsequent Omicrons and variants of Omicron, which continue to have greater lower ID50 values, right? They are going to require less and less particles to infect someone. So if you are in a situation, let's say you're at a music concert, and people are singing and it's indoors and there are thousands of people, your viral load that you may be exposed to may be much greater. And knowing the infectivity of some of these variants, your severity of illness can sometimes be dependent upon that ID50. You know, how many viral particles also that were you bombarded with? Okay, viral shedding here. Once infected with one of these viruses during the prodromal period, prodromal is prior to the actual appearance of clinical symptoms, as well as once those symptoms appear, the infected individual may become a shedder of infectious particles. They may not know it. You may not know it. We're not asking them on the health history form, are you shedding viral particles? We see evidence of this when patients with herpes lesions, they come in, they have the bullous lesion, right? Or it has been opened up and now it is shedding virus particles. You have this open, white, weepy herpes virus lesion that is chock full of viral particles. You don't want to treat a patient during that stage, right? Because you don't want to be exposed to that sort of cross-contamination. Well, we have patients walking around now that are probably viral shedders. We don't know it. They don't know it. It's just respiratory shedding for the most part. Of course, other types of viruses, norovirus, the cruise ship virus, which is not necessarily respiratory initially, but it can be. If somebody is shedding those virus particles, maybe in your toilet, in your office, or sitting on your dental chair, those can become re-aerosolized, and we'll see that. Okay, so we said that dissemination of associated disease depends upon a number of factors, and those include what? The amount of virus released, the amount of virus shed, infectivity of the virus within the released matrix. So the droplets in aerosol or fecal diarrheal discharge, and other excretions that include respiratory secretions, and then of course the survival of the released virus. Not all viruses are robust. Right? Not all viruses will last that long on a countertop or your flooring. And then some will last quite a long time. All right, transmissions of SARS and MERS coronaviruses and influenza virus in healthcare settings. This study is the possible role of dry surface contamination. This was the Kraken variant when I was putting one of the updates together, and I've left this here because it's still valid to today's variants. So this was a few variants ago, but this one is still around, the XBB 1.5. And Trevor Bedford, who's a computational virologist at the Fred Hutchinson Cancer Center in Seattle, suggested that the Omicron subvariant, which this is, has a reproduction number of around 1.6. So every person infected by XBB 1.5 will go on average to infect about 1.6 other people. So the mechanism behind its increased transmissibility hasn't been determined, but it's thought to be a mutation in the spike protein, like all of the other variants, that permits the virus to more effectively latch onto ACE2 receptors that are found on all cell surfaces in the body. When you see and hear about folks with long haul or long COVID, and they may have issues with their heart and other organs, it's because these ACE2 receptors, they're everywhere. They're on all cell surfaces in your body. So this is the doorway through which the virus gets into our cells, through our noses, our throats, and our lungs. Are there any questions or comments? Okay, let's go ahead and continue on. What about virus survival on fomites via aerosol? What are fomites? Fomites are inanimate objects. Counter surface, your dental chair, instruments, they're all fomites. Important factor to consider when assessing risk is the survival, as we said, the continued infectivity of these viruses on these environmental surfaces or fomites or in the air in the form of droplets and aerosol. So we have to talk about our engineering and administrative controls when we talk about aerosol, because first of all of you are the experts at administrative controls. You had to be after the lockdown and you were all back opening your practices. You had to implement more stringent administrative controls, right? What are the administrative controls? The administrative controls have hierarchy over all of your other controls. First of all, you're trying to prevent someone who is ill or maybe the possibility of being ill and infectious from walking in your dental practice to begin with. Now, many of these administrative controls now with COVID-19 have gone out the window, but your health history forms would ask questions, probably still do. Have you been around anyone who's tested positive with COVID? Have you traveled anywhere? You were taking temperatures. You were having the patient wait out in their vehicle in the parking lot maybe and texting you when they arrived, and you were letting one patient in the reception area at a time. You're trying to control the amount of exposure to possible infectious virus particles at the end of the day. That's what you're trying to do. And you do it by preventing someone from coming in the office? Well, we have to be worried about carriers. Again, SARS-CoV-2. Many patients out there walking around right now. Have a friend who went back east, took his wife to an event. Wife came back with COVID or developed COVID. He did not. He just went back home to the East Coast. They had to wait a few days, right? So, did he have COVID or not? Well, he didn't test. He might have had it. He was just asymptomatic and que sera, right? So right now it's a little bit of the Wild West. So your administrative controls, again, we want to reduce risk and place these in the hierarchy of controls, because these patients that may be walking in with any virus, could be shedding virus or spreading it through the air with tidal volume breathing and so forth. So the amount you can keep that reduced, the better. Right. So again, it's all about reducing risk. Engineering controls, we use devices and protocols to mitigate risk. What would those be? Rubber dam. Good old rubber dams. Rubber dams are great for reducing aerosol. Your HVAC. Not all of you have HVAC systems. Glory, who will be talking at 6 o'clock Pacific time, is an HVAC contractor. She can talk to you about HVAC and what you need to consider. Extraoral scavenging devices, of course. UVC, in some offices, you may be using UVC. Many of the healthcare facilities now, the hospitals, have UVC robots that roam from room to room. Defoggers or foggers, pre-procedural rinses, and more. Pre-procedural rinses are considered an unresolved issue by the CDC, but there is certainly quite a bit of research out there that proves that it has some effect in our dental practices and maybe something to consider. All right, the efficacy of an extraoral scavenging device on reduction of splatter contamination during dental aerosol generating procedures. This was an exploratory study. And they found here that extraoral scavenging devices resulted in a 20% reduction of frequency and 75% reduction in mean intensity of contamination of operatory sites. There was a 33% and 76% reduction in mean intensity contamination for the clinician and the assistant, respectively. However, note, when they used rubber dam and four-handed dentistry, it resulted in further reduction. Okay, we spoke about engineering controls, how to mitigate risk, and extraoral suction here. So in this study, using the extraoral suction unit here during the dental procedure, simulations reduced droplet spatter at the dentist eye level, as well as the level of the simulated patient's mouth. Again, it's this study only. And when they used the extraoral suction at level 10 and 4 inches from the simulated patient's mouth, it's like a typodont, I think they were using, less spatter was detected. So according to this study, and this was 2021 in the Journal of the American Dental Association, extraoral suction units were an effective method of reducing droplet spatter during operative dental procedures and can be useful in helping to reduce risk of experiencing COVID-19 spread during dental procedures, which we are still experiencing. Ashley, you haven't received an email yet with the quiz link because the presentation isn't over yet. So hang on to that thought. You'll get it. Laura here. Receptionist is told mother tested positive for COVID, but the rest of the family, 5 patients, will be coming. The office manager allows the family to come for the appointments. Frustrating. See, that is the conundrum right here. My question is, who's running the ship in your practice? Because somebody with some level of authority has got to decide what your protocols are going to be, right? And that's a very good point that you bring up. What is your threshold? If you have a mom who's positive for COVID and the rest of the family is going to be coming, that would not have flown very well in your practice 2 years ago, right? But guess what? Some of them may be positive, right? So the question is, what are you going to do? And the same thing with Carolyn brings up a point. Yes, I have a child coming that doesn't have strep symptoms, but the brother has it. Exactly. So what are your protocols? What's acceptable to you in your practice? I will tell you, after getting this was the first time I had COVID. And my health history is a little complicated because I had Clostridium difficile last year after a dental procedure. So I'm not a candidate for Paxlovid because I can get a recurrence. I'm certainly not a candidate for antibiotics. I'm considered high risk, and I got this in a hospital. And because nobody's masked up, and you can imagine the level of viral spread in a hospital right now in any healthcare setting, including dental practices. So it's something to think about. What are we going to do moving forward? I wish COVID had a season. It doesn't have a season. That's the bad part about it. We know influenza, we've got these respiratory months we've got to worry about, but COVID doesn't have a season. It seems to peak around holidays because people are traveling, they're interacting. The winter's coming, so more people are going to be indoors, right? At least where you are, not here. It's 97 degrees right now. But that's something that we have to think about. You know, who's running the ship in your practice and who's going to make the call. Now, I saw there were a couple of counties in California that made an announcement, Santa Clara County, which is up by Silicon Valley, and they were stating, you know what, we're reinstituting masks for healthcare workers in healthcare settings for the, quote, winter respiratory months. What is that? Well, we used to have winter respiratory months, right? But again, COVID, there is no season for COVID. It's all year round. It would be really naive of us to think that COVID has gone away, because it hasn't. Have you been watching the Taylor Swift saga here? How many people are getting COVID attending those concerts? And now the movie. There was a comedian the other night who had to broadcast from home because he took his wife to the Taylor Swift movie opening premiere, and people were singing and laughing, which you want the world to be joyful again, and he got COVID 3 days later, right? So something to think about. We would have talked about that prior to any patients coming in 2 years ago, right? For Mary, far UVC light is not new. That's correct. It's actually quite old. There's been evidence of the reduction of influenza in long-term care homes with a published study showing a remarkable reduction in the spread and prevention of viruses at least a decade ago. So Mary, I actually teach a course on UVC online and on the ground. And UVC has its advantages and it has its disadvantages. First of all, we can't stare at UVC light. It would destroy our eyes, right? But you'll hear Glory talk about UVC light in HVAC can actually degrade some of your filters and so forth. Number one, not all UVC or far UVC germicidal lighting is equal. And you have shadowing effects as well, right? So it has reduced influenza in long-term care homes. Now, I worked on a study with a UVC robot company here, not a study, a presentation last year. And so they have robots that they've developed that roam hospital halls and they send them into hospital rooms after the patients have been discharged, which are very effective for Clostridium difficile and MRSA and so forth. Okay, what are your thoughts on the new COVID shot? I had the flu shot 2 weeks ago. I have my appointment on Friday for the COVID. You know, Kelly, I hate to get into the whole vaccine theory. I'm going to tell you something. So I'm much older than all of you. I'm so old that I had the smallpox vaccine. All right. And my vaccination schedule is handwritten by my mother, because I didn't have vaccines for many things. I had the disease. I had every measles. I had mumps. I had chicken pox. In 1968, I had the Hong Kong flu and I developed viral pneumonia and I missed 5 months of school. So that tells you how old I am. So my mother used to say, she was a nurse, if you don't get that vaccine, because I would hem and haw about getting the flu vaccine, she said, you know, then you haven't been that sick. Well, I have been that sick. I do remember having pneumonia when I was a child and not being able to move. I do remember my brother developing meningitis from German measles. I don't ever want to be that sick again. I hope and pray that Clostridium difficile, there will be a vaccine, because the next time I might die. So I don't have the luxury of saying, geez, you know, I don't want to get that vaccine. So I have had the influenza vaccine. I've had all of the COVID vaccines. I had the newest COVID vaccine. And you know what? I'm happy I did. I'll tell you why. I've had 4 family members die of COVID. None of them were vaccinated. So I have a divided family, the maskers and the vaccinated folks. And then I've got the other side, right? We still love each other. We just don't agree. But unfortunately, I lost 4 of those people I loved. So I do believe in it, whether or not you do. And that's your personal preference. But I do. I wonder now, had I not been vaccinated, where I'd be with what I have right now. I might have ended up in the hospital with pneumonia. Thank you, Lori. And, you know, I have an uncle that's had COVID now 4 times. He's 83. He went into a hospital for a valve replacement. He got COVID while he was in there. And he was in the hospital for 60 days because of COVID, not because of the valve replacement. So there are so many things swirling around in my head about this. What can we do to try to honor everybody's belief system and keep everybody safe? Is that possible? I'm not sure. You know, there's so much science naysayers out there. I happen to be a scientific person, but again, I do respect people's opinions. But that's my personal choice, right? So again, my mother used to say, if you don't get that or you don't take that medicine, then you haven't been that sick. And I don't ever want to be as sick as I had Clostridium difficile, I'll tell you that. So the minute Pfizer gets their vaccine approved, I will be the first in line. UVC lights, many affect laser glasses. Yeah, they degrade. Oh, hi, Dr. Cutcliffe. Yeah, that's correct. So we do have to think about that. UVC germicidal radiation or germicidal lighting. You'll see these devices that are good for, you know, putting your cell phone in the device, your tablets and so forth, but they're not specific for everything we're concerned about in dentistry. Yeah, I'm sorry to hear that, Sharon. So again, far UVC light, a new tool to control the spread of airborne mediated microbial diseases. And you'll hear Glory talk about some of the studies that they looked at. Okay, And again, UVC lighting in your HVAC is only going to work as long as the air is passing through, and it's got to pass through slow enough to have effect. And usually the air is pushed through your HVAC system pretty rapidly. All right, masks, do we need to go into all of the details? I think you're all pretty well versed. Well fitting is the most important here. And NIOSH, of course, per the requirements. Supposedly, you can filter out at least 95% of the airborne particles, and fit testing is required. Now, I have to tell you, I was wearing a KN95 when I went into the hospital, but I had to take it off for some of the tests that I have performed. CT scan, that sort of thing. But unfortunately, they put me in a room with a patient who had a cough that sounded like COVID to me, and they said they couldn't move me. They didn't have another space for me. So there you go. All right, so operatories, what can we do? Specific applications by room area, of course, intraoral devices, extraoral scavengers, individual room filtration, HVAC with UVC. Again, this is controversial. UVC as well. Consider reducing the objects left on your counters. You've got a lot of stuff on your counters. You don't need all that stuff, perhaps. Why expose it to the aerosol? Put it away. Have nice, clean counters that you can keep disinfected. Use closable dispensers for your PPE and so forth. When we look at your reception area and front desk, again, individual room filtration, your HVAC, and so forth. Your dental laboratory, benchtop filtration, room filtration, HVAC, UVC, and then your restrooms. So room filtration devices, your HVAC, etc. Consider toilet plume in your practice. If you have a restroom in your practice, you want to be sure that you are using something to help mitigate the aerosol that is released when you flush the toilet. And we have a couple links for you that you can take a look at. I think you'd be surprised. And the problem here is that the bioaerosol that's released here can include many different pathogens from fecal waste. And it can become aerosolized and not just stay in your restroom. So something to think about here. And there are the links, including Clostridium difficile, which can become aerosolized. So we have a few. The toilet here was important for me to share with you. Okay, dental practice design as we close here. What will the dental practice of the future look like? It may very well look like the dental practice of the 70s, where the closed dental operatories were returned because we can have more control over the aerosol. And MPOX, dental practices can reduce the spread of MPOX through awareness screening, infection control, and certainly through aerosol management, aerosol cleaning the air, because the respiratory spread exists for MPOX as well as skin-to-skin contact. I have more resources on our website for you. This Saturday is our infection control course. Please sign up for it. It's very popular. And IQAir has sponsored that course, so we definitely want to make sure you attend. 2 courses on antibiotics that you want to take a look at here. Dr. Palmeyer, who is with the American Dental Association, has joined me in promoting antibiotic awareness so we can help reduce the spread of antimicrobial resistant infections and or Clostridium difficile. Also Dr. Goff as well, and those courses are available for you. There are my citations. For further questions, you can reach out to me through the website. And I am going to go ahead and introduce Glory Dolphin Hummus to you. And at first, I am going to show you a quick video here. Okay, for those of you that are still here, Thank you so much. Please stay tuned because we have Glory to talk to you about aerosol cleaning of the air, filtering of the air, as well as air quality management. How can you determine what the air quality is in your dental practice? She's going to talk to you about that. At the top of the screen, you see a banner. Our sponsor is IQAir. Tap there, go to the URL. You can save it for later, and it's going to give you quite a bit of information. So for now, I want to go ahead and show you a video. And this video to me is really exciting and it's terrifying at the same time because I'm claustrophobic, so I'm going to admit that right now. But it is exciting to watch, and this is by IQAir.
IQAir President Frank Hammes is about to step into this specially designed chamber to personally prove the effectiveness of the IQAir Health Pro Plus. We have 2 officers here to ensure the grenades are properly fired. Now, obviously, this is a demonstration you don't want to try at home. We're about to release noxious smoke and chemicals into this chamber. Your home can be filled with harmful fumes from household cleaners and other pollutants, but nothing compares with what we're about to release. Now Frank is sitting close to the IQAir and will only breathe the fresh filtered air coming directly out of the Health Pro Plus. Remember, he doesn't have a gas mask. The whole chamber is now filled with noxious smoke and chemicals. Look closely. You can see Frank breathing the clean air stream coming directly from the Health Pro Plus. The IQAir Health Pro Plus is clearing the room completely.
Everything good.
Okay, everyone, I'm very pleased to introduce to you Glory Dolphin-Hammes. She is the CEO of IQ North American Division, a Swiss-based air quality technology company. Glory is a certified indoor environmentalist and licensed HVAC contractor specializing in air quality, and she is also a member of the EPA's Air Quality Work Group. She resides in Southern California with her husband, Frank, and 2 sons. And we want to be sure to thank IQAir this evening for the continued support of our infection control program. So Glory, I'm going to turn this over to you, and I'll be here advancing your slides.
Okay, thanks for the awesome introduction there. Yes, today hope you guys enjoyed the video as well. It was always nice to see that video every time. It was really fun shooting that video as well. So we're talking today about solutions for dental practices, and of course, the execution of dental work really increases your risk overall of being exposed to potentially harmful airborne contaminants, viruses, bacteria, also mold related and other biological contaminants. It's important that when we're using high-speed drills and ultrasonic scaling equipment that we have some protection as well, and we'll be talking about what exactly we can do to protect ourselves within the operatories. This is a really interesting video. This gives you a little bit of a taste of what it's like here in generating aerosols within with certain procedures taking place. So we'll play that. Great. So what's important to say is that this is what we can see with the naked eye. What we can see is in such a high micron size range. It's really in the 100 and 200 size range. So really what we can see is always going to be coarse particles, but then there's fine particles and ultrafine particles. Ultrafine particles meaning you're going to have your viruses, you're going to also have bacteria, and that is really consisting of particulate matter that you cannot see. There's 3 steps to improve air quality, and this is very specifically in prioritization order. So prioritization order meaning if there was one thing you could do, that's going to be on number 1. So the one thing to do to make sure you don't skip this step is source control. And within the dental environment, that is extraoral suction. So source control, extraoral suction is what you can do in order to prevent your aerosolized biocontaminants from spreading throughout the operatory, but also ensuring that it's being filtered out. Number 2 is ventilation. Ventilation is the process of mixing in outside air in order to dilute the biocontaminants that are in the air. So ventilation really it works through the very specific process of dilution. Air cleaning or recirculation, a lot of people go to this step first, but it actually is the third step in terms of what should be prioritized within any indoor air quality environment. And indoor air quality meaning just within not just dental environments, but all air quality environments. Of course, recirculation, that is the third priority, and it's about recirculating the air through HEPA filters or through mechanical filtration throughout the particular facility. And this is really a lot of the times we go to this step first when we should actually go to this step to the third step. Great. Now this is actually a clean air facility that we have. I believe that is Dr. Garcia's his practice within Miami. I guess that's why it has those cool lights there. But he's using that open bay, and I believe he is doing braces and not just your regular standard dentistry, but lots of braces in which there's lots of adjustments taking place. And he has his dental pro that he rolls around with a flex back from patient to patient. Great. Now, this is a screenshot of our actual clean air facility experience within La Mirada. Here, we don't have very poor air quality, so we are at 100% in terms of being able to have that high level of cleanliness. So we compare always the outdoor air to the indoor air, and what our clean air facilities are able to accomplish time and time again is over 90% cleaner air in comparison to the outside. So that is really how we're consistently comparing that. We're comparing inside air quality in terms of particulate matter to the outside air quality, and we engineer to really produce over 90% in terms of our level of cleanliness. This is Dr. Kelly Blodgett out in California. And this is really a part of the clean air facility that he has, and he's working on a patient using the Dental Pro and the FlexVac. And what needs to be said, it looks a little bit further away than it's supposed to be, but that FlexVac hose needs to be within 12 inches of the patient's mouth while you're working. And that 12 inches will provide over 92% in terms of containing the aerosolized particles in what is produced. So you're able, as these particulate matter, as the aerosolized particles are being generated, you're able to reduce them by over 92% when the edge of that hose is within 12 inches of the patient's mouth. And please keep in mind that if you're able to work closer with the hose, then that will actually increase the efficiency and capture rate to more than 92%. Now we're talking about air cleaning, source control using the FlexVac. That's a little bit of an older FlexVac, I believe, with that hose. And you see that operatory is pretty much so a closed operatory for that one particular patient. And source control, of course, being the priority. Recirculation, this is at Garcia's orthodontic practice. And you can see that he is using the Health Pro Plus, we call it the HPP sometimes, to recirculate within the reception area that he has. Yes, so the key is extraoral suction. There, you'd be really surprised. We were able to watch that video and to see that 15-minute procedure. That's just the particulate matter, the coarse particulate matter that we're able to see. Now, of course, what we're able to see in terms of particulate matter, coarse particulate matter only accounts for about 1% of all particles that are in the air. There are 10% of particles in the air that are in the category of what's called fine particulate matter, which is a little bit smaller than what you can see. And actually, in terms of ultrafine particulate matter, over 90% of particles by sheer number fall in the category of ultrafine particulate matter. So that is the size range that can actually stay in the air because it's so light, fluffy, will stay in the air for an indefinite amount of time. So that's really why you want to really focus on extraoral suction. We saw the video, but of course, if we can see it, that's not going to be ultrafine. That's not in the ultrafine particulate range. That's not in the size range of viruses. It's not in the size range of bacteria because that's in a size range that you cannot see. And really, I think it was a good video to take a look at, but we also need to understand how exactly viruses, bacteria are transmitted. And in terms of COVID, of course, it was about what you couldn't see because COVID is in the size range that it could be transmitted by breathing and talking within 1 meter, basically, of the other person that might have it. So that's really truly the reason you're working in close range. Why extraoral suction is especially important. Nanomax. Now, this is about really our HVAC products, and these are standard, really filter sizes that are 2 inches, and they are able to fit into an HVAC system that has a 2-inch filter slot. Many folks have been recommending MERV 13 filtration, but our Nanomax filtration, it's actually exceeding the MERV 16 standard. So it's literally like having HEPA filtration within your HVAC. These filters are definitely having a high surface area, so they are about, I believe, about $100 to $150 per filter. They last generally about 1 year long, so it does really help to get these filters really installed within your HVAC system if you have access to your HVAC system. It has very low pressure drop and reduces really leakage along the, or leakage overall within the return. and allows you to have a very, very high efficiency rate, over 95% efficiency rate with a 2-inch filter. If you have like a MERV 8, MERV 11 filter, it will be compatible with that kind of system that's able to take a MERV 8 or a MERV 11 filter. Yes, and love talking about the AirVisual Pro and the AirVisual Outdoor. So we have AirVisual Pros set up indoors, and we get an average. We group them, and we get an average. Now we're pretty lucky there because we have high-end filtration, but also with the clean air facility, you're able to have the high-end filtration that you're really truly able to show off your air quality with the AirVisual Pro. You can also take the AirVisual Pro around while you're conducting procedures, making different changes, alterations to your procedure to see which types of processes will reduce the actual aerosolized particulate matter generation. So you can use really this AirVisual Pro, quantify how clean or how dirty the air is, make improvements, measure, measure, measure. It's really fun. It's really quite a good way if you have like a clean air champion within your practice to test out and to make constant improvements to reduce particulate matter with your procedures that you're conducting. So definitely would recommend that. And with the clean air facility, we are constantly comparing indoor to outdoor air, and you'll have really customized solutions that are designed to give you at least 90% reduction in the air quality, in the particulate matter when compared to the outdoors. Awesome. Great. Are there any questions that you guys might have here? Great. I don't think we can see the video there, but let's see. I'm going to see if there's any questions in the chat. I don't see those. Awesome. All right. Well, thank you all so much. It was great to spend some time with you, and I love coming to these courses. So please be sure to invite me to your next ones. Thank you so much. Have a good one. Thanks. Bye-bye.